Good afternoon, dear students. Today we should discuss an extremely important topic, the management of a patient with pulmonary embolism and pulmonary heart disease. Pulmonary heart disease, a pathological condition that develops as a result of pulmonary hypertension due to pathology of bronchopulmonary system, vessels of the lungs, or thoracodiaphragmatic disorders, which causes hyperactivity of the right ventricle of the heart, hypertrophy and or dilation of the right ventricle, and the formation of right-type heart failure. There are three main groups of etiology factors. The first group is about diseases, primarily affecting the passage of air to the alveoli, bronchopulmonary form, 80% of all cases. Chronic obstructive pulmonary disease, bronchial asthma, emphysema, bronchiectasis, bronchiolitis, pulmonary fibrosis, pneumoconiosis, tuberculosis, systemic connective tissue diseases like systemic lupus erythematosus or dermatopolymyositis, Beck's sarcoidosis, fibrosing alveolitis, cystic fibrosis, malignant infiltration, and lung resection. The second group, diseases primarily affecting the chest, diaphragm with limited mobility, or thoracodiaphragmatic form. Pleurisy, fibrothorax, kyphosis, kyphoscoliosis and other deformation of the chest, multiple injuries of the ribs, Pickwick syndrome, obesity, myasthenia gravis, botulism, and idiopathic alveolar hyperventilation. Third group, diseases primarily affecting the pulmonary vessels or vascular form. Primary pulmonary hypertension, pulmonary vasculitis, pulmonary embolism, compression of the pulmonary artery from the outside by aneurysm or tumor, cancer lymphangitis, and thrombosis of the pulmonary artery. Actually, pulmonary hypertension is a pathological and pathophysiological disorder that may involve multiple clinical conditions and can complicate the majority of cardiovascular and respiratory diseases. The main diagnostic criteria of pulmonary hypertension is the presence of signs of hypertrophy and dilation of the right ventricle of the heart and presence of pulmonary hypertension. Treatment. First group of treatment is supportive. You can prescribe anticoagulants, antiplatelet agents, diuretics, oxygen, cardioglycosides, and inotropic drugs. Second group, it is specific treatment for pulmonary hypertension. There are 5 main groups: calcium channel blockers, amlodipine and diltiazem, analogous of prostacyclin, beroprost, epoprostenol, iloprost, treprostinil, endothelin receptor antagonists like pacentan, ambrisentan, macitentan, phosphodiesterase type 5 inhibitors, sildenafil, vardenafil, tadalafil, and guanylate cyclase stimulators, riociguat. And the last group is IP receptor agonists like selexipag. This slide shows you efficacy of drug monotherapy. And you can see main groups, all main groups of drugs for treatment of pulmonary hypertension. Calcium channel blockers, endothelin receptor antagonists, phosphodiesterase type 5 inhibitors, guanylate cyclase stimulators, prostanoids, and IP receptor agonists. The composition of the guidelines task force reflects the multidisciplinary nature of pulmonary hypertension, including members of different medical societies, associations, and working groups. The current document follows the 2 previous ESC and ERC guidelines published in 2004 and 2009, focusing on clinical management of pulmonary hypertension. The task of developing ESC guidelines also includes the creation of educational tools and implementation programs for the recommendations, including condensed pocket guidelines versions, summary slides, booklets with essential messages, summary cards for non-specialists, and an electronic version for digital applications like smartphones. Implementation programs are needed because it has been shown that the outcome of disease may be favorably influenced by the thorough application of clinical recommendations. And now let's discuss management of the patients with pulmonary embolism. This document follows the previous European Society of Cardiology guidelines, published in 2000, 2008, and 2014. Guidelines summarize and evaluate available evidence with the aim of assisting health professionals in proposing the best management strategies for an individual patient with a given condition. Guidelines and their recommendations should facilitate decision-making of health professionals in their daily practice. However, the final decisions concerning an individual patient must be made by the responsible health professionals in consultation with the patient and caregiver as appropriate. Epidemiology. Venous thromboembolism, clinically presenting as deep venous thrombosis or pulmonary embolism, is globally the third most frequent acute cardiovascular syndrome behind myocardial infarction and stroke. In epidemiological studies, annual incidence rates for pulmonary embolism range from 39 to 115 per 100,000 population. For DVT, incidence rates range from 53 to 162 per 100,000 population. Cross-sectional data show that the incidence of venous thromboembolism is almost 8 times higher in individuals aged after 80 years than in the fifth decades of life. Pulmonary embolism may cause about 300,000 deaths per year in the United States, ranking high among the causes of cardiovascular mortality. In 6 European countries, with a total population of 454.4 million, more than 370,000 deaths were related to venous thromboembolism in 2004, as estimated on the basis of an epidemiological model. Of these patients, 34% died suddenly or within a few hours of the acute event, before therapy could be initiated or take effect. Of the other patients, deaths resulted from acute pulmonary embolism that was diagnosed after death in 59%, and only 7% of patients who died early were correctly diagnosed with pulmonary embolism before death. Let's talk about predisposing factors for venous thromboembolism. There are many factors: strong, moderate, and low risk factors. Strong risk factors: fracture of lower limb, previous venous thromboembolism, spinal cord injury, hospitalization for heart failure or atrial fibrillation or flutter within previous 3 months, hip or knee replacement, major trauma, myocardial infarction within previous 3 months. Moderate risk factors: arthroscopic knee surgery, autoimmune diseases, blood transfusion, central venous lines, intravenous catheters and leads, chemotherapy, congestive heart failure or respiratory failure, erythropoiesis-stimulating agents, hormone replacement therapy, depends on formulation. Also moderate risk factors: IVF, oral contraceptive therapy, postpartum period, infection, specifically pneumonia, urinary tract infection and HIV, inflammatory bowel disease, cancer, highest risk in metastatic disease, paralytic stroke, superficial vein thrombosis and thrombophilia. Weak risk factors: bed rest more than 3 days, diabetes mellitus, arterial hypertension, immobility due to sitting, increase in age, laparoscopic surgery, obesity, pregnancy, and varicose veins. Respiratory failure in pulmonary embolism is predominantly a consequence of hemodynamic disturbances. Low CO results in desaturation of the mixed venous blood. Zones of reduced flow in obstructed pulmonary arteries combine with zones of overflow in the capillary bed served by non-obstructed pulmonary vessels, result in ventilation-perfusion mismatch, which contributes to hypoxemia. Finally, even if they do not affect hemodynamics, small distant emboli may create areas of alveolar hemorrhage resulting in hemoptysis, pleuritis, and pleural effusion, which is usually mild. This clinical presentation is known as pulmonary infarction. Its effect on gas exchange is normally mild, except in patients with pre-existing cardiorespiratory disease. Definition of hemodynamic instability. It could be in three types of patients. Patients with cardiac arrest, need for cardiopulmonary resuscitation, patient with obstructive shock, with systolic blood pressure lower than 90 mmHg, or vasopressors required to achieve a blood pressure higher than 90 mmHg despite adequate filling status, and end-organ hyperperfusion, altered mental status, cold clammy skin, oliguria, anuria, increased serum lactate. And third type of patients with persistent hypertension, systolic blood pressure less than 90 mmHg or systolic blood pressure drop more than 40 mmHg, either lasting longer than 15 minutes and not caused by a new onset arrhythmia, hypovolemia, or sepsis. Clinical presentation. It could help to confirm, to put diagnosis for patients with pulmonary embolism. Main clinical manifestations are dyspnea, chest pain, presyncope or syncope, hemoptysis, hemodynamic instability. In some cases, pulmonary embolism may be asymptomatic or discovered incidentally during diagnostic workup for another disease. The combination of symptoms and clinical findings with the presence of predisposing factors for venous thromboembolism allows the classification of patients with suspected pulmonary embolism into distinct categories of clinical or pre-test probability, which correspond to an increasing actual prevalence of confirmed pulmonary embolism. The value of empirical clinical judgment has been confirmed in several large series. Clinical judgment usually includes commonplace tests such as chest X-rays and electrocardiograms for differential diagnosis. However, as clinical judgment lacks standardization, several explicit clinical prediction rules have been developed. Of these, the most frequently used prediction rules are the revised Geneva rule and the Wales rule. Both prediction rules have been simplified in an attempt to increase their adoption into clinical practice. The simplified version have been externally validated. On these slides you can find Geneva criteria or Geneva rule. It is very important to check presence of previous pulmonary embolism or DVT, to check heart rate, surgery or fracture within the past months, hemoptysis, active cancer, unilateral lower limb pain, pain on lower limb deep venous palpation and unilateral edema, and age more than 65 years. Regardless of the score used, the proportion of patients with confirmed pulmonary embolism can be expected to be about 10% in the low probability category, 30% in the moderate probability category, and 65% in the high probability category. When the two-level classification is used, the proportion of patients with confirmed pulmonary embolism is 12% in the pulmonary embolism unlikely category and 30% in the pulmonary embolism likely category. A direct prospective comparison of these rules confirmed a similar diagnostic performance. It is very important to avoid overuse of diagnostic tests for pulmonary embolism. The pulmonary embolism rule-out criteria were developed for emergency department patients with the purpose of selecting on clinical grounds patients whose likelihood of having pulmonary embolism is so low that diagnostic workups should not even be initiated. And now we should discuss main changes on ECGs in patients with pulmonary embolism. Main criteria: deep S wave in first standard lead, deep Q wave in third standard lead, and presence of negative T wave or T inversion in third standard lead, right bundle branch block, and T inversion in V1, V2, V3. The similar ECG with deep S wave in first standard lead, deep Q wave and negative T in third standard, right bundle branch block and negative T. Presence of deep S wave in first standard, Q wave and negative T in third standard lead, T wave inversion, V1, V2, V3, and presence of arrhythmia, ventricular extrasystole. It is also very typical for pulmonary embolism. And now let's discuss laboratory tests. D-dimer testing. The negative predictive value of D-dimer testing is high, and normal D-dimer level renders acute pulmonary embolism or DVT unlikely. On the other hand, the positive predictive value of elevated D-dimer levels is low, and D-dimer testing is not useful for confirmation of pulmonary embolism. There are many reasons of elevation of D-dimer. It could be cancer, or hospitalization, or severe infection or inflammatory disease, and even during pregnancy. The quantitative enzyme-linked immunosorbent assay, or ELISA-derived assays have a diagnostic sensitivity of 95% and can be used to exclude pulmonary embolism in patients with either low or intermediate pre-test probability. The specificity of D-dimer in suspected pulmonary embolism decreases steadily with age to 10% in patients after 80 years of age. The use of age-adjusted cutoffs may improve the performance of D-dimer testing in the elderly. A multinational prospective management study evaluated a previously validated age-adjusted cutoff, age multiply 10 mg per liter, for patients aged more than 50 years in a cohort of 3,346 patients. Fifth method, computed tomographic pulmonary angiography. Multi-detector computed tomographic pulmonary angiography, or CTPA, is the method of choice for imaging the pulmonary vasculature in patients with suspected pulmonary embolism. It allows adequate visualization of the pulmonary arteries down to the subsegmental level. Strengths and weaknesses of these tests. Strengths: readily available around the clock in the most centers, excellent accuracy, strong validation in prospective management outcome studies, low rate of inconclusive results, only 3 or 5%, may provide alternative diagnosis if pulmonary embolism excluded, short acquisition time. And weaknesses or limitations. Radiation exposure, exposure to iodine contrast, limited use in iodine allergy and hyperthyroidism, risks in pregnant and breastfeeding women, contraindicated in severe renal failure, tendency to overuse because of easy accessibility, clinical relevance of CTPA diagnosis of subsegmental pulmonary unknown. And now I want you to look at these slides, these photos, CT scans, and these arrows point out the blood clots in pulmonary arteries. Lung scintigraphy. The planar ventilation perfusion VQ lung scintigraphy scan is an established diagnostic test for suspected pulmonary embolism. Perfusion scans are combined with ventilation studies, for which multiple traces such as xenon 133 gas or krypton 81 gas, technetium 99M labeled aerosols or technetium 99 labeled carbon microparticles can be used. Being a low radiation and contrast medium sparing procedure, the VQ scan may preferentially be applied in outpatients with a low clinical probability and a normal chest X-ray, and also in young particularly female patients, in pregnant women, in patients with history of contrast medium-induced anaphylaxis, and patients with severe renal failure. On this slide, you can find a perfusion defect. Normal situation and pulmonary embolism. Also perfusion scans. On this picture, you can see perfusion defect with absolutely normal ventilation. The purpose of the ventilation scan is to increase specificity. In acute pulmonary embolism, ventilation is expected to be normal in hyperperfused segments, mismatched. Pulmonary angiography. For several decades, pulmonary angiography was the gold standard for the diagnosis or exclusion of acute pulmonary embolism, but it is now rarely performed as less invasive CTPA offers similar diagnostic accuracy. The diagnosis of acute pulmonary embolism is based on direct evidence of a thrombus into projections, either as a filling defect or as amputation of a pulmonary arterial branch. Patient with pulmonary embolism and filling defects. You can see a huge blood clot and amputation of pulmonary artery. Also, thrombus in pulmonary artery and amputation. Echocardiography. Acute pulmonary embolism may lead to right ventricle pressure overload and dysfunction, which can be detected by echocardiography. The combination of a pulmonary ejection acceleration time measured in the right ventricle outflow tract less than 60 with a peak systolic tricuspid valve gradient less than 60 mmHg, 60 to 60 sign, or with depressed contractility of the right ventricle free wall compared to the echocardiographic right ventricle apex, McConnell sign, is suggestive of pulmonary embolism. In a hemodynamically compromised patient with suspected pulmonary embolism, unequivocal signs of right ventricle pressure overload, especially with more specific echocardiographic findings, 60 to 60 sign, McConnell sign, or right heart thrombi, justify emergency reperfusion treatment for pulmonary embolism if immediate CT angiography is not feasible in a patient with high clinical probability and no other obvious causes for right ventricle pressure overload. On this slide, you can find graphic representation of transthoracic echocardiographic parameters in the assessment of right ventricular pressure overload. Compression ultrasonography. In the majority of cases, pulmonary embolism originates from deep venous thrombosis in a lower limb and only rarely from upper limb deep venous thrombosis, mostly following venous catheterization. Finding a proximal DVT in patients suspected of having pulmonary embolism is considered sufficient to warrant anticoagulant treatment without further testing. Integration of aggravating conditions and comorbidity into risk assessment of acute pulmonary embolism. In addition to the clinical, imaging, and laboratory findings, which are directly linked to pulmonary embolism severity and pulmonary embolism-related early death, baseline parameters related to aggravating conditions and comorbidity are necessary to assess a patient's overall mortality risk and early outcome. Of the clinical scores integrating pulmonary embolism severity index and comorbidity, the pulmonary embolism severity index, or PESI, is the one that has been most extensively validated to date. The principal strength of the PESI lies in the reliable identification of patients at low risk for 30-day mortality for PESI classes 1 and 2. And now I want you to look at these slides with PESI, Pulmonary Embolism Severity Index. And there are many criteria, many points that we should check. Of course, it is age, sex, male sex, cancer, chronic heart failure, chronic pulmonary disease, pulse rate more than 110 beats per minute, systolic blood pressure less than 100 mmHg, respiratory rate more than 30 breaths per minute, temperature less than 36, altered mental status, arterial oxyhemoglobin saturation less than 90%. Due to this index, due to this criteria, we can put a class of PESI. Class 1, less than 65 points, very low 30-day mortality risk. Class 2, 66 to 85 points, low mortality risk. Class 3, 86 to 105 points, moderate mortality risk. Class 4, 106 to 125 points, high mortality risk. And Class 5, more than 125 points, very high mortality risk. Risk assessment of acute pulmonary embolism begins upon suspicion of the disease and initiation of the diagnostic workup. At this early stage, it is critical to identify patients with suspected high-risk pulmonary embolism. This clinical setting necessitates an emergency diagnostic algorithm and immediate referral for reperfusion treatment. So let's discuss treatment of these patients. Of course, first of all, you should give the patient hemodynamic and respiratory support. It includes oxygen therapy and ventilation, pharmacological treatment of acute right ventricular failure, mechanical circulatory support and oxygen, and advanced life support in cardiac arrest. Parenteral anticoagulation. In patients with high or intermediate clinical probability of pulmonary embolism, anticoagulation should be initiated while awaiting the results of diagnostic tests. This is usually done with subcutaneous, weight-adjusted low molecular weight heparin or fondaparinux or intravenously unfractionated heparin. This is the list of main low molecular weight heparins and fondaparinux. You can prescribe enoxaparin, tinzaparin, deltaparin, najoparin, and fondaparinux. Non-vitamin K antagonist oral anticoagulants, or NOACs. NOACs are small molecules that directly inhibit one activated coagulation factor, which is thrombin for dabigatran and factor 10A for apixaban, edoxaban, and rivaroxaban. And please pay your attention that only dabigatran has a reversal agent like idoracizumab. Non-vitamin K antagonist oral anticoagulant. Dosage for dabigatran 150 mg 2 times per day and 110 mg for patients older than 80. Rivaroxaban 15 mg twice daily during 3 weeks. After that, 20 mg 1 time per day. Apixaban 10 mg 2 times per day during 7 days, and after that 5 mg twice daily. Edoxaban 60 mg once daily. For patients with creatinine clearance from 15 to 50 ml per minute, 30 mg 1 time per day. Vitamin K antagonists, or warfarin, have been the gold standard in oral anticoagulation for more than 50 years. When vitamin K antagonists are used, anticoagulation with unfractionated heparin, low molecular weight heparin, or fondaparinux should be continued in parallel with the oral anticoagulant for 5 days and until the international normalized ratio value has been from 2 to 3 for 2 consecutive days. Reperfusion treatment and systemic thrombolysis. The greatest benefit is observed when treatment is initiated within 48 hours of symptom onset, but thrombolysis can still be useful in patients who have had symptoms for 6 or 14 days. Thrombolytic doses and contraindications. You can prescribe recombinant tissue type plasminogen activator or streptokinase or urokinase. And of course you should remember, you should keep it in your mind, contraindications for fibrinolysis, absolute and relative. Absolute contraindications: history of hemorrhagic stroke or stroke of unknown origin, ischemic stroke in previous 6 months, central nervous system neoplasm, major trauma, surgery, or head injury in previous 3 weeks, bleeding diathesis, and active bleeding. Relative contraindications. Transient ischemic attack in previous 6 months, oral anticoagulation, pregnancy or first postpartum week, non-compressible puncture sites, traumatic resuscitation, refractory hypertension with systolic blood pressure more than 180 mmHg, advanced liver disease, infective endocarditis, and active peptic ulcer. Percutaneous catheter-directed treatment. Mechanical reperfusion is based on the insertion of a catheter into the pulmonary arteries via the femoral road. Different types of catheters are used for mechanical fragmentation, thrombus aspiration, or more commonly, a pharmacomechanical approach combining mechanical or ultrasound fragmentation of the thrombus with in situ reduced dose thrombolysis. Surgical embolectomy. Surgical embolectomy in acute pulmonary embolism is usually carried out with cardiopulmonary bypass, without aortic cross-clamping and cardioplegic cardiac arrest, followed by incision of the two main pulmonary arteries with the removal or suction of fresh clots. Vena cava filters. The aim of vena cava interruption is to mechanically prevent venous clots from reaching the pulmonary circulation. Most devices in current use are inserted percutaneously and can be retrieved after several weeks or months, or left in place over the long term if needed. Potential indications include venous thrombosis and absolute contraindication to anticoagulant treatment. Second indication is recurrent pulmonary embolism, despite adequate anticoagulation, and primary prophylaxis in patients with a high risk of venous thromboembolism. Different types of vena cava filters. Huge blood clot from pulmonary artery, and it is long after pulmonary embolism. Chronic treatment and prevention of recurrence. The aim of anticoagulation after acute pulmonary embolism is to complete the treatment of the acute episode and prevent recurrence of venous thromboembolism over the long term. The risk for recurrent venous thromboembolism after discontinuation of treatment is related to the features of the index pulmonary embolism event. This table shows examples of transient or reversible and persistent risk factors for venous thromboembolism, classified by the risk of long-term recurrence. As active cancer is a major risk factor for recurrence of venous thromboembolism, but also for bleeding while on anticoagulant treatment, is specifically dedicated to the management of pulmonary embolism in patients with cancer. So, recommendations for the duration of anticoagulation after pulmonary embolism in patients without cancer. Therapeutic anticoagulation for at least 3 months is recommended for all patients with pulmonary embolism. And for patients with first pulmonary embolism, secondary to a major transient or reversible risk factor, discontinuation of therapeutic oral anticoagulation is recommended after 3 months. Patients in whom extension of anticoagulation beyond 3 months is recommended. Oral anticoagulant treatment of indefinite duration is recommended for patients presenting with recurrent VTE not related to a major transient or reversible risk factor. And oral anticoagulant treatment with VKA for an indefinite period is recommended for patients with the antiphospholipid antibody syndrome. NOx. If extended oral anticoagulation is decided after pulmonary embolism in a patient without cancer, a reduced dose of the NOx apixaban 2.5 mg or rivaroxaban 10 mg should be considered after 6 months of therapeutic anticoagulation. And in patients who refuse to take or are unable to tolerate any form of oral anticoagulants, aspirin or zolidexid may be considered for extended VTE prophylaxis. Recommendations for the duration of anticoagulation after pulmonary embolism in patients with active cancer. For patients with pulmonary embolism and cancer, weight-adjusted subcutaneous low molecular weight heparin should be considered for the first 6 months over VKS. Edoxaban should be considered as an alternative to weight-adjusted subcutaneous low molecular weight heparin in patients without gastrointestinal cancer. And rivaroxaban, the same situation, should be considered as an alternative to weight-adjusted subcutaneous low molecular weight heparin in patients without gastrointestinal cancer. Recommendations for pulmonary embolism in pregnancy. Acute pulmonary embolism remains one of the leading causes of maternal death in high-income countries. Low molecular weight heparin is the treatment of choice for pulmonary embolism during pregnancy. In contrast to VKS and NOx, low molecular weight heparin does not cross the placenta and consequently does not confer a risk of fetal hemorrhage or teratogenicity. So, for diagnosis, perfusion scintigraphy or CTPA with a low radiation dose protocol should be considered to rule out suspected pulmonary embolism in pregnant women, and CTPA should be considered as the first-line option if the chest X-ray is abnormal. And treatment. One more time. Therapeutic, fixed dose of low molecular weight heparin based on early pregnancy body weight is the recommended therapy for pulmonary embolism in the majority of pregnant women without hemodynamic instability. Thrombolysis or surgical embolectomy should be considered for pregnant women with high-risk pulmonary embolism. A great number of guidelines have been issued in recent years by the European Society of Cardiology, ESC, as well as by other societies and organizations. Because of their impact on clinical practice, Quality criteria for the development of guidelines have been established in order to make all decisions transparent to the user. The recommendations for formulating and issuing European Society of Cardiology guidelines can be found on the ESC website. The ESC guidelines represent the official position of the ESC on a given topic and are regularly updated. The guidelines are developed together with derivative educational material addressing the cultural and professional needs for cardiologists and allied professionals. Collecting high-quality observational data and appropriate time interval following the release of European Society of Cardiology guidelines will help evaluate the level of implementation of the guidelines, checking in priority the key end points defined with the European Society of Cardiology guidelines and task force members in charge. Thank you for your attention, and I wish you good luck.